I'm joined by Isaac Longobardi, who's our director, and we've got a couple of wonderful speakers for you today. First things first, if you would like, it's optional, but if you would like, please feel free to chat in your name if you want, your title or your affiliation. And if you happen to be part of a large organization or you work for a government agency, please, share the type of agency you work with. If you're in Medicaid or you're in the Division on Aging or the survey agency or whatever. I know we have some people from, I think, Texas and Michigan and Ohio who may be joining today, and other states. So please share with us, let us know who you are. What we're talking about today is a topic that through our first 2.5 years as the Moving Forward Coalition has gotten a lot of attention and a lot of I would say, people really saying this is important to them. This is part of the heart and soul of what all of us together do in nursing homes, is, person-centered approaches to care, person-centered approaches to care planning. And all of that starts by asking people about their goals, their preferences, and their priorities, asking what matters to them when they first come to live in a nursing home and at other points along the way. So, again, I know from my own experience as a nurse practitioner for many years in different nursing homes, when I would start and meet someone for the very first time, I always tried, I did not always succeed, but I always tried to sit down face to face and, spend time getting to know them and just ask, what is it, tell me about yourself, tell me about your life and things like that. So you're going to hear a lot more about the wonderful people who've worked on this guide and process and the details of it. The guide is available on our website. You'll hear more about that. But I'll introduce Laci and Addie in a moment, but they've worked together with a lot of other people. Some of you are on this call, but committee members that have been very much a part of this development. Greg Alexander, Terry O'Malley, Tatiana Shippey, Susan Ryan, Penny Cook, Tara McMullen, Anna Fisher, Tonya Roberts, Mary Lucialfi, and many others. So again, you're going to hear more from Laci and Addie about the guide and the process, and we hope to have time for discussion to hear from you all as well. And then at the very end, we'll let you know about an opportunity that just came through where you might be able to help identify some folks to get involved with some of our colleagues in the state of Maryland. So I'm going to introduce our two speakers, Addie von Zutphen, who is currently the program coordinator, thank you for waving, for the GPP Guidebook Pilot Project in the state of Kansas. And she's got a background in social work and gerontology. She has over 10 years of experience with nursing homes and leading nursing home teams. And you will find she is very enthusiastic about person-centered care and creating positive environments where residents are directing their daily lives. And then the group has been led and continues to be led by Laci Cornelison, who was a gerontologist from the very beginning, apparently when she was first born. And, she's been hanging out with older adults, while her mom said she should keep busy, and she just turned it into her passion. So she now has actual credentials as a gerontologist, a long-term care administrator, social work license, and she's got deep experience in directing leadership in clinical practice, innovations, and she leads the PEAK program in Kansas and does national advocacy and research. So with that, Laci and Addie, I'm going to turn it over to you. Laci, I think you're driving to start.
Yes, I'm going to share my screen, so bear with me here for a second. And I have a PowerPoint. When Alice said I kind of was a gerontologist from the start. My mom was a nursing home administrator for 45 years. So if you work in this field at all, that I spent a lot of time with her at work because it's a lifestyle, not a job. And so that's where I found my passion for working with older adults. But I knew that nursing homes had some things to do to improve, and that I kind of said I wouldn't work in nursing homes, but I found that with person-centered care, we could do it better and we could do it different. So I'm going to kind of lead this show, and Addie, I'm going to call you out when we get to the part where I want you to join in. Okay. Awesome. Well, first I want to say it's a pleasure to be here, and I know some of you on the call have been part of this work, and I just feel really privileged to work with such wonderful people all across the country who are passionate about this issue. And it has created a really good end product that we continue to refine to help elevate residents' voices in their own care and to get what matters to them most. So I'm excited about sharing that. Just for some context for people who may not know where this came from, the NASM report really called out some need for improvements in nursing homes. And one of the goal areas that they identified was to deliver comprehensive, person-centered, equitable care that ensures the health, quality of life, and safety of nursing home residents, promotes resident autonomy, and manages risk. Pretty lofty goal. One of the recommendations in there was to identify care preferences, ensure the residents' care preferences are documented in the care plan, and to implement and monitor the residents' care plan that reflects their preferences. And that's really what Committee 1 honed in on and had as our priority, and where the guidebook that we're going to talk about came out of that work. We also collaborated with Group 6, who is the measurement group, and Goal 7, which is the health information technology in all nursing homes group, to really integrate across all those pieces this theme of elevating residents' goals, priorities, and preferences. And so we developed an action plan jointly related to that. And out of that really came the development of this guide to addressing residents' goals, preferences, and priorities. And the link to that will be at the end of this presentation, and I can make sure that this gets shared with you. But really, the guide has developed a process for staff to identify, document, and implement residents' goals, preferences, and priorities. It's developed an interview for evaluators to ask residents, care partners, direct care staff, and senior leaders about care concordance. That's Goal 6. And then developed an outline for a digital tool that nursing home residents will be able to complete by themselves or with a care partner to share their goals. So those last two are really what the other two committees worked on. And I'm going to highlight today the guide, the first one. And I think all of us on this call can say that we want to see residents empowered to have and to do what matters to them. And so the guidebook really developed this process that is highlighted here visually of collecting GPP information, documenting that in the care plan, aligning the care that's actually delivered to the resident to their identified GPPs, and then implement it. See it actually turn into fruition and action within how we provide care. And then to evaluate that. And this evaluation component is really that care concordance that we talk about, that we see as part of the development long-term. And then as we evaluate that, we go back. Now, right now, even though the tool doesn't exist, it doesn't mean we don't evaluate it. We have some ways that we can do that informally, but we hope to integrate that on a large scale to go back and collect, keep going through that process as we go. So this is going to take a little bit to buffer, but this is a video that kind of gives you the overview here of it.
If you're watching this video, you most likely work in a nursing home. So, how can we provide the best possible quality of life for people living here? To build a positive relationship with each individual that starts with key principles, such as working to gain his or her trust. We know that residents have a lot going on related to their daily activities and care. Working in a nursing home is incredibly rewarding, but responding to each person's needs and requests can sometimes be challenging. Each of us is asked to work with individuals every day, supporting each person to do things like socialize with others, get to meals, take a walk outside. But our team's mission is more than just those activities. That's why getting a clear idea of what matters most to each resident is so important. And that is where we want to focus our time as much as possible. We want to encourage each resident living here to direct us as to how they want to live day to day as much as possible. Goal discussions should be part of our practice with every resident every day. This is part of our commitment to keeping each person's goals and wishes at the center of their daily life. Listen to one example of how acting on one's goals enhanced the person's quality of life.
Miss Houston, is that what you prefer to be called?
I do not prefer to be called at all.
Well, what should I call you?
Merle.
Merle. Can I
Yeah.
call you Merle?
You may.
All right. What kind of things do you like to do throughout the day?
What do I like to do?
How do you like to spend your leisure time?
Well, having spent most of my life as a librarian, I like to read, and unfortunately for my friends, I like to make recommendations for what they would like to read, whether they know it or not.
Okay. What time do you go to bed at night?
9 to 10.
The guide and process you will learn about, addressing residents' goals, preferences, and priorities, provides step-by-step guidance on how to establish an approach to identify, document, and implement each person's goals. While the guide and process will help get the team started, each staff member on the team will provide feedback and help to shape the process for individuals living in your community. Hearing and acting on each person's goals and wishes focuses everyone on promoting quality of life and keeps humanity at the center of everything that we do. Thank you very much for the work that you do every day. We look forward to working with you and your team.
So that's really a promo piece that we can share with the public about, what this is all about, but also for, as we think about getting this information out to nursing homes that may not be doing this, that they can see kind of just generally what this is all about and hopefully get them excited about it a little bit. Really the guidebook is about taking these concepts that I just described and turning it into action in real organizations, real nursing homes providing care. So it's kind of a how-to manual for putting the resident voice at the center of care planning through GPPs. And care planning, I want to think about, broadly, because care planning starts really at the beginning and then is a process that's really reinforced by regulations. And person-centered care planning, for sure, is something that's really important in the regulatory process. So it has it's practical, it has steps and tips, and it has specified tools within it. So let's kind of explore that a little bit more. One of the things I want to say for context is the guide, as it was being developed, had direct resident involvement in that development. And there may even be some people on this call that were a part of that through resident one-on-one conversations and focus groups. And then there was AdVault data in the HIT committee that was direct resident input as well. So it's really informed and has been vetted by residents as well. There was also a provider feedback group that had engagement in the process to review the guidebook, to kind of test out at a high level. How does this hit with you? How do you think this would work? Do you think this would be helpful? What could be changed? What could be better about it? And so we really took that feedback and tried to incorporate it from the beginning. So the guide itself, an overview, it has 3 parts to it. One is kind of the context. It's the background, purpose, and objectives. It gives a description of how to use the guide, some definitions of what goals, preferences, and priorities are. It talks about engaging nursing home residents, care partners, and the interprofessional team or the care planning team for addressing GPPs. It talks about the federal regulations related to addressing GPPs and how that interacts. And then an introduction to the training, which is in the tools and resource section and how that is intended to be used. So it gives some context for the guide and the process. And then the next part is kind of the meat of the actual process, the identifying, documenting, and implementing of resident GPPs. It really just runs a team through the entire process from start to finish in a pretty succinct way. And it directly links to tools that could be used directly in the context of that process. So in the guide, if the process talks about a specific tool or collection of tools, it will link directly to that and bounce the person in the PDF right to that tool. This section has a resident checklist. It has the GPP domains listed out. It has the specific recommended or identified assessment tools for collecting and identifying GPPs. This was done with in a very systematic way, a systematic search of the literature, both the peer-reviewed literature and the gray literature. And so there's a succinct listing of those there, as well as one that is a condensed version if they might be a little too overwhelming. And then the last part is identifying, documenting, and implementing the GPPs. It focuses on the care planning, the meeting, the process, and best practices, and care plan interventions, like tips and best practices for caregivers accessing and making updates and changes to GPP information and care plan interventions. So that's the second part. And then the last part of the guide are the actual tools. And I just put a sampling here. You can go to the actual guide to see the whole thing, but there's a welcome packet orientation template for homes where it could be included in an admission packet and a welcome packet and details out what is a care plan and what does that look like here in this specific organization. So this is kind of an ideal outline of it that could be used or modified to reflect the specific way that you do it in your particular organization. And then there is a direct care quick reference sheet that could be put or integrated into electronic systems like Matrix Care or Point Click Care or whatever the home uses. You could integrate it into that. It could be printed off and put, in strategic locations, any way that a direct caregiver would have easy access to the information. It's kind of distilled down information that also includes specific preference information that the resident has. And then here's the last example I'll share is a direct care staff care plan input tool. One of the things the guide highly suggests is direct caregiver involvement in the care planning process. A caregiver that works directly with a resident whose care plan is happening. And this would be filled out beforehand, just like other members of the care plan team do leading up to the care plan. The assessments, direct caregivers would do this. And then they could bring that to the care plan meeting as a point of reference of things that they could share during that time, or would help them answer questions that either the resident or their family or specified people might have. So one of the greatest compliments that I feel that we got during this process was when the residents got to see the guidebook. Barb Bowers led that process, and the resident said, I wanted to pass on to you that they were thrilled with the guide. They all said they felt heard, respected, and appreciated. I know much of what you did was based on research, but it also is clear that you integrated many of their suggestions. And that was the highest compliment, I think. So the next step for us and what we're currently in right now is K-State, Kansas State University Center on Aging, where I work, is now piloting the guidebook with 6 nursing homes here in Kansas. To actually test it out and see what the experience is. So we want to look at the feasibility of the guide, the usability, the practicality for all of the different stakeholders. And our goal is to revise the guide based on the feedback with the support of the advisory group, which meets bi-monthly right now in tandem to the pilot project, and then develop a strategy for scale and spread of the guide to a larger group of nursing homes. So this is kind of a summary of our sites, and Addie has been working directly with these homes from the get-go, and she's going to share just a little bit here pretty soon about that experience. The intervention is really to introduce the guide to these 6 homes. We've done a pre-test already with them, which is really gathering what are you currently doing related to GPPs and what is your current care planning process, and then develop a individualized action plan for each of those sites to integrate some of the recommendations in the guidebook and then to roll them out. They're also doing a care plan facilitator training that uses the training incorporated in the guidebook. And then each site will implement for 3 to 5 months and do check-in meetings with Addie and our team. And then we'll do a post-test and debriefing with each of the homes and collect that data as we go. So the pre-post survey, what we did is we collaborated with Committee 6 to develop this. But there's a resident survey, a care plan team member survey, and direct care staff survey that finds out what's your current process. And then we determine the current process related to the identification, documentation, and implementation. And we are collecting qualitative and quantitative data related to that. So then at the very end, we'll also have focus groups at each of the sites that's going to be facilitated by an outside party to really gather the team's perspective on the guide, the process, and specific feedback about that. So Addie, I'm going to stop right now from my perspective and have you chime in on your thoughts on the pilot study right now. Anything you want to add?
Yeah, absolutely. So right now we're in that action planning phase. So far we were on site at all 6 of the homes for the pre-testing and data collecting at the beginning. During that, we spent a lot of time talking about current practices and seeing each individual home, what they wanted to implement and what they kind of felt like they could improve upon. So it's been a lot of fun working with each individual home and their teams, figuring out how their team functions and figuring out how the guidebook can really help them. So far, we're having a lot of fun. Everyone it's encouraging, it's exciting. And, people that have even been that have been administrators for 20+ years are reading the guidebook and thinking, oh yeah, why don't we follow up after care plan meetings? So it's been a lot of fun kind of gathering feedback already and seeing where homes are at and how the guidebook fits in for them.
Awesome. Thank you. And Addie's just done a great job of really learning each of the teams and figuring out best ways to help come alongside them as well. So it's, as you can tell, it's pretty high touch at this point. And we're working with the advisory group to think about the next year. We're going to roll it out to 20 homes and thinking about as we move forward, how might this look different as we're working with a greater number of homes and getting some really great ideas and feedback from that group. But as you can tell from this pilot, it's really an iterative process. We're doing the intervention, but we're also updating the guidebook as we go. And it's all happening kind of in real time, keeping detailed notes, thinking about what those updates will be and trying to do them as we go along. We're not to that phase yet, but that's what we foresee. And then the advisory team, as I talked about, and committee 6 and 7 will be engaged too throughout the pilot study and those revisions, and being reviewing the results as we go along. So the guide is on the Moving Forward Coalition website, and it can be downloaded straight from there. So I encourage you to go check that out and look at it in more detail. So I'm going to stop there and turn it over for questions.
Great.
To stop sharing, but hang
there
on
you
just
go.
a second. There we go.
There you go. Well done. All
Yeah.
right. Well, thank you guys both so much. That was a lot. And I think you gave everybody a really good overview. You know, I chatted in a couple of invitations to people to, you know, unmute themselves and chime in and give us their thoughts or their questions. So maybe we start with the questions, as you said, but we've got a wonderful variety of people in different roles on this call. So again, if you have the little raise hand icon and you want to do that, then Isaac can also make sure that we unmute you if you request to be unmuted. We'd love to hear from people. And don't be shy, because we're not a scary group of folks. We're very down to earth.
While we're waiting for the questions, I might comment a little bit more about the different homes and sort of their characteristics and how we selected them. One, we know that working with these homes are not going to represent all the homes in the country, but we needed to work intensively with a few homes. And so we did try to have just a variety of size with the homes. So we have our biggest home, it has 93 residents. Our smallest home has 30 some residents. We tried to have a mix of for-profit and not-for-profit, and then a mixture of homes in terms of 5-scale rating and on the nursing home compare site. And so we do have a blend of different characteristics like that in there. But of course, it's not a large scale representative sample, but it'll give us kind of a start. And then as we move forward, we'll start, getting other homes involved as well. So.
Great. Well, I see Cheryl Huckins had put her hand up. So Cheryl, will turn to you. For everybody else on the call, Dr. Huckins is a medical director, and she works with the Palt Med Medical Directors Chapter in Michigan that she leads. And she's also a coach and part of our team on the Moving Forward Michigan project, where we also have Nancy Swires, our director, on this call. So Cheryl, go ahead.
Thank you. I'm wondering if you've started to think about how you will keep this up to date. If you've got plans or thoughts of how often you come back and circle around and say, are these still the goals?
Would you like me to address that, Alice, or do you want to?
Yeah, no, I think you should address it. Go for it.
Yeah. Well, I think right now the goal is to, it's kind of consistently being updated as we get information. I think it will be something that's what we need to decide as a group with moving forward, how often we revisit it and look at it. But it does need to be an evolving and working document. Yeah, as big changes come up or there's new best practices.
Great. And Maria Moen is coming to us. She's got a strong background in technology and has worked with us and some of our teams on a lot of this background and thinking about how to integrate it into some digital tools. So Maria, you'll need to come off of mute. So Isaac, can we unmute Maria? There we go.
Wonderful. Thank you, Alice. So yeah, I've been working with Moving Forward since we started. I have kind of a logistical question. So, here we are and we're capturing what's important to the people that we serve. How have you guys handled a resident identifying something that's important to them? And it can hit multiple disciplines, right? Because the care planning process is typically very discipline specific. What do you guys do with more overarching goals that may be distributed and not have a single discipline within the community that is responsible, but multiple disciplines that partner together? Have you observed any confusion sometimes that either multiple disciplines are addressing it, or gosh forbid, they assume the other discipline is, and it sort of hits the floor? I was just curious about logistics.
I love this. Yeah.
Yeah.
I love this question so much because I think the guide itself really pushes homes to get out of that discipline specific care planning mode. And it really encourages people to work in an interdisciplinary fashion and write the care plan, not in silos, but as a whole person, and incorporating the goals, preferences, and priorities across all of the different interventions or problem areas or care plan specific pieces, instead of having just a goals, preferences, and priorities intervention, that it is incorporated throughout the whole thing. And I also believe that having a direct caregiver involved in the care planning process pushes that envelope as well. So the process itself tries to break down some of that stuff. But to your question, is it hard? Is it challenging? Do you run into problems? Yes, probably, especially because we're trying to fight against, a system that has reinforced those discipline specific things over time. But yeah.
And I would also add that, Laci and Addie and that whole group of people I mentioned in the beginning, they focused on a couple of the key issues that you raised, Maria, which is, it's not necessarily the nurse who's leading the interprofessional team. It might be the therapist. It might be somebody from nutrition. It might be the social worker, any of the above. And Laci and Addie and the team have done a really good job talking about the non-hierarchical nature of teams. This is not like I'm in charge and this is my team. Like, no, it's not, the idea. So we're really trying to create that non-hierarchical environment. And again, if you read the guide and then go through the process, you'll see that it's reinforced in a lot of places. Related to how this intersects with other work, I wanted to turn to a question in the chat, Laci and Addie, which is from Christine, who said, how does this work integrate with or complement the MDS section F interview, which is about, preferences and priorities and stuff? What do you guys think? I know you talked about it.
Yeah, so actually some of that section sort of stems from the PELI, and the PELI is one of the recommended tools. But as we worked with a lot of the people engaged with the Moving Forward Committee 1, we recognized it's not enough. It's not enough information to truly drive residents' goals, preferences, and priorities to then integrate it fully into care. It's a great place to start, but it's not enough. So yes, if you're gathering that information on section F, it's certainly important. It's important to take that information and integrate it into what you're doing, but it's just not robust enough to get a picture of the person's goals, preferences, and priorities. So it complements the other pieces, but it's just on its own. It doesn't drive a process like this that is resident driven. Does that make sense? Does that answer it? I also saw a follow-up question to what Cheryl might have had, and that I may have misunderstood, that how often are we reevaluating residents' GPPs and encouraging that those be revisited and that sort of thing. And it's really integrated into the care plan process that we should be doing it on a daily basis. Really, if somebody learns something about a resident, that there is a flexible way to communicate that information and update information in a live form. And that is somewhat integrated into the guidebook for recommendations, and that we're definitely revisiting it at the care plan. So quarterly, if there's a significant change, and more intensely on an annual basis. So in general, that's kind of the same response, but recognizing that goals, preferences, and priorities change, and we get more specificity with them. We may learn at the beginning that they're kind of night owls, but what does that actually look like? Okay, we know they're going to stay up later, but what does that look like for them? And how is that evolving and changing over time? And so, yeah.
And a lot of the goals and preferences and what's the priority for me, what matters to me, have nothing to do with health. If you start asking me about what I really care about, a lot of it is not going to have anything to do with health. One of the sort of related topics, social determinants of health. We just recently have a paper coming out in April on, social prescribing, which is, if I'm a nurse practitioner or a physician and I'm a prescriber, I can prescribe things that are related to transportation, related to housing, related to joining or thinking about joining a senior center or something like that. So again, what Laci and Addie are talking about is really broadening beyond, just a narrow focus on health. So Nancy Stevens, you had your hand up before. I don't know if you still have a question, but we can unmute you.
Looks like she's inviting us to attend or observe one of her care plan meetings. That's a great invitation.
Yeah, the majority of my question was actually just answered in the last bit of that conversation. So I put my hand down, but thank you. Yeah, if anyone wants to attend one of my care plan meetings, they're really quite interesting. There's a lot of dialogue, great questions, great answers, back and forth. There's also a lot of trauma, a lot of pushback, and a lot of lies. How do residents combat that when they don't have anyone with them to advocate? And what happens when the ombudsman errs on the side of the facility when they try to sort of assert their basics, their basic needs.
Yeah, thank you, Nancy. And Nancy and Marguerite and Cindy and others are on this call who are regular contributors to moving forward and give us a lot of feedback on a lot of parts of the processes and the guides, such as this one. There's a few other people on the call who I maybe I'll just call on you to see if you have anything you want to add. I know Kathy Lieblich, I know you've worked on these issues for a long, long time, and just wondering if you have anything else to add from Pioneer, Live Oak, or any of the other groups that you've participated on. If we can unmute you.
Yeah, I did. Thanks, Alice. No, I think the work that Laci and Addie are doing is just wonderful. And, the really big deal after you work with the 6 pilot homes is getting other homes to use it around the country. And I think it would be a great tool if a culture change coalition, state culture change coalition, wanted to take it on as a project to work with homes, because we have found over the years that getting coaching, culture change coaching or whatever type of coaching, really helps with adherence to some new thing. And they have somebody to kind of like report to in terms of what they've done. There's that accountability thing. So I think that would be important going forward if this is going to be used in a lot of places around the country.
Yeah, I think that's great, talking about scale and spread and how we get there. And Laci and Addie talked about that a little bit as well. The culture change coalitions are a huge opportunity. And, some of them have strengthened over the years. Some of them have gotten a little quieter over the years. But I think, re-engaging with those organizations in the states that still have people working on them, I think is so important. Laci and Addie, Christine wrote a follow-up question in the chat about what you answered before, which is, after you get all this information on the preferences, do any of the tools and templates in the guide help to facilitate how you might restructure staffing in order to be able to meet the goals and preferences of so many people? I see Cindy nodding. Cindy always gives us good thoughts. Because again, what if some of these things are on evenings or nights when there's fewer staff, or I don't know, what would you guys say about that adaptation?
Sure. So the specific GPP guidebook does not have it in there. What I would say about that though is that is a reality, right? And so it can be one of the well, unintended consequences of, you know, gathering preferences is doing that. And what I'd say is this is where the tools that are out there related to culture change and implementation of person-centered care can come in really handy. So in our work in Kansas, and Addie is a part of that work, we can point them to some of, for instance, some of the peak tools that are available that can help with some of those things. And so I would say that there are some tools out there. They aren't necessarily in the guidebook, and they aren't a blanket, you know, if this, you know, if this preference causes more need for staff on, you know, evenings or whatever, this is what you should do. Right, that it's not going to be cookie cutter because every resident population is going to be different. The preferences are going to be different, but it's really about, for the peak work, it's really about consistent staffing, and it's about breaking down the hierarchy of your organization so that you can shift and change staff scheduling around residents' needs, and then that's resident driven. And so I would point to those. If anybody has other things to say about that, I would encourage you to speak up or raise your hands, or Addie, if you would have anything to add, go for it.
I don't know if others would have things that they want to add also, but I just, I'll call on one other person if he wants to say anything. Paul Falkowski's on this call, and Paul's been a contributor and involved with us with some work we did in New Jersey, and he has an organization of volunteers and others. So Paul, do you want to say anything also about, you know, activities, music? I know some of the background that you bring to this conversation that's really helpful.
I thought I was going to escape.
Not from me.
All right. Anyway, no, the truth is it's all I can do to remain quiet. What I'm working on is adding the companion volunteer to the mix. And this would be somebody that's highly qualified, somebody that's been screened, trained. And so this is not a one-off. It's not someone that's just going to come in and do an activity and leave, but you'd have a cadre of maybe 4 or 5 people like this in a community. And I did this in Omaha, Nebraska for a number of years. But anyway, at one of the Peli meetings, I brought up the fact that volunteers could collect a lot of this data or even meet some of these needs. And so it doesn't have to always fall on the volunteers, or excuse me, the care staff's list. And so again, that's something I'm working on right now. I'm based in Philadelphia. But the group that we had in Omaha, they were diamonds. We had about a 60% attrition rate right up front. They couldn't get through the screening process, or they didn't have the desire to do that. But the ones that did were amazing, and they were doing fundraisers for the community. They were engaging other kinds of activities like time slips or validation therapy, and so on. So these are people that are, I would describe them as mid-career, semi-professional, now looking to give back to their community. So that's my short answer.
Well, thank you so much for that. That was a great answer. It always is from when you contribute. And I would just say, you know, this is really important for us all to think about, right? Because it's not, I know we call them nursing homes, and I'm a nurse, but it's not about nurses. It's about the residents and what they tell us is most important to them. And we have to listen, and we have to do a much better job listening than we've done in the past. And as I said earlier, a lot of it is it's social things. It's, you know, when you ask nursing home residents what their top concerns are, it's almost always food and activities, right? And, you know, that's for years, that's sort of been the case. So, you know, there may be other things that are on people's minds, but I think those things are really, really important. And I love the conversation today about, you know, how we might consider scaling and spreading some of this. And I know we already heard from Maria Moen, but I just want to go back to, again, the kinds of things that she and her company work on are about digitizing some of these opportunities, like what Laci and Addie have described. And, they've worked with Maria and other companies too on how can we build these questions about goals, preferences, and priorities into some of these digital tools. Not that that's always the answer, but it can be part of the answer. So I want to turn back for a moment to the chat, and another good question from Christine, which is about cross-training staff into alternate roles. And could that be helpful to supporting, doing more to meet the needs of residents and their preferences? She said she's thinking more about ancillary staff being trained as CNAs, and vice versa, for consistent coverage for thinner staffing days, which of course, as we all know, is a huge issue right now. Laci and Addie, what do you guys think about that suggestion? You already answered it.
Absolutely, yes, yes, unequivocally, yes. And really thinking about, even as Paul was kind of talking about, is really thinking outside the box in how we've typically provided care in nursing homes, is really equipping people to the I love that you're chatty, Christine, so keep it up. You're asking the really important real life questions. But the more capability you have, even if your job isn't specifically a CNA, even as I was a team lead in a dementia care area, I got cross-trained in absolutely everything I could, so that if a resident sat down for a meal, at 10 o'clock in the morning, and I was the one that was available, I could ask, what do you want to drink? I knew I had access to a book that told me what their dietary needs were, what their allergies were, things like that. So I could provide service to them right then and there, because I had that cross training. And so the more we have of that, the more we can do right there, instead of saying, oh, we'll have to wait for this person to come, but whatever your role is, the more capacity you have, the more that we can meet the needs right there.
Right. And again, one of the most difficult things for someone who lives in a nursing home or is anywhere in the healthcare system to hear is when a staff person says, that's not my job. And I understand where that comes from. It's like, you can't do something you're not trained to do. Like, we do understand that, but that's a really hard thing for someone living there to hear. What they really want to hear is, let's tell me what it is you need. I'll go figure out who's the best person to help you with that. Or again, if you can have the cross training so that as much as possible, everybody is, allowed under their scope of their license or certification to do the work. I think that's really, it's so valuable. I mean, we've been in, again, I know I don't need to pick on people continuously, which I've been doing, but in the work we're doing in Michigan nursing homes, when we went around, and actually I had the opportunity to tour with, the administrators and directors of nursing, and, they would stop along the way. They'd see things that were out of place. They would put them in the correct place. They'd stop and talk to staff members, call them by their name, but they were really engaged with the direct care workers and teams in a very genuine way. And that made a real difference in to the culture in the nursing home. So I would just say everything that you guys are saying is really important. Maybe I'll just ask one more person. I know she joined late, but maybe she may want to contribute here. Jenny Chin Hansen. I saw you joined. With your experience with AGS and so many national organizations, PACE and everything else, do you have any other thoughts about kind of spreading and sharing some of this work? I know you've been involved with the committee too, with other nursing homes around the country, or any additional guidance for us.
Oh gosh, I don't know. I apologize. Somehow this populated my calendar at 4 o'clock, but I'm in Pacific
You're
time.
on Pacific time, right?
So I was ready for the call later today. So I apologize. I don't think that I have anything to contribute at this moment. It's funny, I've spent 3 hours this morning on another call regarding geriatric emergency departments. And
Yeah.
the same, you were on it. I get the two. And the scale and spread stuff, was part of that conversation. And so I think part of it is looking for areas that have a leadership that does bring in other people. And part of it is just getting kind of a little bit of momentum going, but in addition to spreading broadly for interested individuals. But we noticed from the call this morning that like the VA is a big tight system that's huge, but places that have kind of a natural community where whoever may be in a leadership position and engaged in this can bring along just a few more people to start a cadre. Because otherwise we do it, we get great people, which is as I said, it's an and, it's not an or, but the ability to start building a little bit of a community so that it's maybe geographic, that they help each other a little bit more, that the kind of sharing that might go on because they have a relationship already. I think the building a cluster that can show with maybe a few facilities together, you could do a lot together, and you don't have to do it all by yourself.
Right. That's always good advice. Thank you. Thank you so much. That's actually a great framing for kind of wrapping up here. So, so two more things that Isaac and I just wanted to share as we wrap up here, which is Nancy Kusmal is one of our members of our committee, and moving forward, she's a social work professor at the University of Maryland School of Social Work. And there's a student there she's working with who's developing an advanced care planning implementation quality assessment tool specific for nursing homes. So very specific and very much related to what we do. They're looking for some expert panelists with experience conducting or documenting advanced care planning conversations. So, some of you have a lot of this experience, and if you're interested, it might be a couple of hours of work. You might have students or people you mentor who would also be interested. Please let us know. Let Isaac know in the chat or email us and let us know you'd like to be connected, and we'll put you in touch with Nancy and the team there. And then finally, we have our next coalition conversation on February 6th from 1 to 2. And that's going to be on how nursing homes fit into the age-friendly ecosystem and age-friendly health systems, which is another significant project that we have. So there's going to be information for how to register on our website soon. So I just chatted that in. So thanks, Maria, for saying you'll sign up. We'll share your information with Nancy, put you in touch. So just to wrap up, Laci and Addie, we want to say thank you guys so much for your wonderful presentation and overview and conversation today. This was a great conversation. Any final thoughts for folks on the call, or any final ideas from you? And I certainly think we're going to look forward. We're eager to hear as the pilot progresses. Addie always has great things to share from her experiences in the field, and Laci is involved with all aspects as well. So anything further from you guys?
I would just say that our goal is to scale and spread this across the country to all nursing homes so that residents can do what matters most to them. And so as we do that, if you have connections that help us reach other nursing homes or strategies that you would suggest, we just really welcome that. So
fantastic. And Isaac, I know you're managing tech for everybody and in the background, but anything more from you before we wrap up here?
No, it's any of this registers for anyone on this call, please do email us at info@movingforwardcoalition.org. We can connect you with the right person, whether that's Nancy Kuzmal for the study or Laci and Addie to talk about strategies for scale and spread, or somebody else in the coalition. So our line is always open. We're constantly monitoring that email and it goes straight to me. So we look forward to hearing from you guys and working with you guys.
Great. Well, thanks everybody for joining. We really appreciate it. And we will talk to you. If not beforehand, we hope we'll see you on February 6th. So thanks, everybody.